Thank you for joining us for this evening's webinar, Treatment Options for Overactive Bladder and Bowel, presented by Dr. Anthony Woodruff. Dr. Woodruff earned his medical degree from the University of Arkansas for Medical Sciences and completed both his urological residency and surgical internship at Ochsner Medical Center and Louisiana State University. Dr. Woodruff completed a fellowship in minimally invasive urologic oncology at Virginia Mason Medical Center in Seattle, Washington, and served as the director of robotic surgery at Northwest Medical Center in Fayetteville, Arkansas. He joined Arizona Urology Specialists in 2009. He practices out of our Scottsdale office and is board certified by the American Board of Urology. Welcome, Dr. Woodruff.
Thank you, Jennifer. Glad y'all could make it. Hopefully this will be informative. I'll say right off the bat that while the title of the lecture is neurostimulation for control of urine and bowel, I'm not going to focus on the bowel part of it because that's not what we as urologists do. It definitely has a function there, but I'm really not expert in that. That would be, if anyone has those kind of questions, that would be something to bring up with either your colorectal surgeon, oftentimes called proctologists, or with a gastrointestinal physician. So I don't really have answers for that, but this is going to focus mainly on voiding dysfunction. We're going to talk a little bit about voiding dysfunction. We're going to talk about our agenda. Basically, people having problems with the way they pee, men and women, is a super, super common thing in the world. In the United States, it's no different. Medtronic is the company that kind of put this slide deck together. There are other companies that have the ability to neurostimulate and neuromodulate, but InterStim and Medtronic have been out by far the longest and have the most data. So our agenda tonight, hopefully at the end, people will understand bladder control a little better, understand the care, what we call the care pathway, which is, the treatment options and how you put them together and stack them. And then Medtronic, the bladder control therapies. This slide says that 1 in 6 American adults have overactive bladder. I think that number is probably actually quite a bit higher, maybe as much as 50% of people, I think is more like it. That number is low because a lot of people just simply don't seek care. They don't seek treatment, and a lot of it is because of a miseducation or misunderstanding, and people they think it's just part of getting older and that's what they have to live with because that's what their mom or their aunt or their grandmother or grandfather had. It's just part of life, when in reality that's not necessarily true. It affects both men and women, and if you just leave it alone, it's going to get worse, and it can really lead to some downside events like loss of sleep is a common one, being too insecure to leave the house because you don't want to have an accident, things like that. It's one of the most common problems in American adults. And this slide goes back to what I was saying, incontinence is not a normal part of aging. Is it common? Yes, but there's a difference in common and normal. People who are using the restroom more than 8 times a day, people who got to go right then when you got to go, you got to find a bathroom. One of the most common things I hear day in, day out is I have to plan everything I do around the restroom. If I'm at the airport or if I'm, going to a meeting, I have to make sure I know where the bathroom is. And that just can really affect your quality of life, especially, I had a patient last week who got back from Europe, and I don't know if anybody's been to Europe, but public bathrooms are just not readily available. And it really kind of ruined their whole trip. They were there for 2 weeks with their family, and it messed their whole trip up, and it was too bad. You have to monitor how much you drink. You have to worry about using pads. And oftentimes people are too embarrassed to really go seek treatment and tell their friends and family about it. So how does bladder control work? Well, it's pretty complex, but this is a kind of a simplification. Basically, when your bladder fills with urine, if it works normally, what happens is the bladder fills, that stimulates nerves in your pelvis, which go to the spinal cord, which sends a signal to the brain, which sends a signal back to the spinal cord, which sends a signal to your pelvic nerves of that feeling of needing to go. And that's in normal urination that causes you to go, okay, it's time to go to the restroom, and then you need to go empty your bladder. You really don't have any control over that. And people think they control their urination when in actuality, it's no different than your breathing or your heartbeat and that kind of stuff. It really is more of control of the autonomic nervous system, out of our control. So if that gets out of whack, then that's when people start having to go too frequently, to go too urgently. Their stream is weak. Their stream starts and stops. And that's all because the nervous system is out of whack. And that can be caused by lots of different things. It can be caused by, disease states like diabetes, bad habits, or even not bad habits, because I drink coffee, right? And I love coffee, and I hope I never have to stop drinking coffee. But when I do, it makes me have to go to the bathroom more, just like it does most people. Several types of foods and drinks affect those sensations. Certain types of medications can be a causal, as well as other things that people have, like childbirth, pregnancy, injury, that kind of thing can all cause issues. So you basically have 3 common kind of overarching indications for when you seek treatment and when we actually use this neuromodulatory device. One would be stress incontinence or leakage with coughing or sneezing. One is urinary retention that's not caused by something blocking the bladder. And then the other is overactive bladder, which is a broad category, things like, frequency, urgency, slow stream, getting up at night too much. Urinary incontinence is, like I kind of covered, is where, you bend over, you leak, you cough, you sneeze, you pick up something, you leak, climbing stairs, going from sitting to standing, all these things, and that's not normal. And that absolutely can be helped by lots of different things, not just neuromodulation. It's also urinary retention is when you have your bladder full and you're not able to empty it. And that can oftentimes be seen with, you can actually feel someone's bladder above their pubic bone, or they are, the classic thing, and this usually happens in men, it happens in women too, is, they're minding their own business and all of a sudden they realize they haven't urinated in several hours and they feel very full and they can't urinate. And oftentimes that necessitates a catheter, which people are never very happy about having to have that. Urge incontinence is different than stress incontinence. That's when you feel like you need to go to the restroom, and before you reach the restroom, urine starts coming out. That can happen to men and women. It can happen frequently, it can happen occasionally, but usually by the time if people are having that kind of issue, they've usually developed a bladder problem that really probably medically needs to be treated. And then there's urgency and frequency, which we kind of already covered. There are a lot of things you can do for overactive bladder. There is kind of a care pathway that most urologists follow. Most urologists don't offer InterStim. Some do, most don't. But the care pathway is usually the start of it is usually pretty much the same for any urologist that you go to. And that would be going to your doctor, telling them about your symptoms. And the doctor probably would do some workup, maybe look in your bladder, maybe do some imaging, make sure that there's some diagnoses that are ruled out. And then once we identify you having overactive bladder or urge incontinence, and we now know that's the problem, then you usually start with behavioral modification, changing your diet, going to see a pelvic floor physical therapist, seeing if doing some of those simple things can shore up your problem and make it where you don't need any other treatments. And that's always preferred because that's cheap and easy and has very limited risks, little to no risk actually. And then beyond that, there are medications, and there are medications in several different classes. And usually we give a trial of those medications for 4 to 6 weeks and have you back and say, okay, how did this affect you? How are the side effects, et cetera, et cetera. And then advanced therapies. And we're going to talk about some of those advanced therapies now. We talked about the biofeedback and bladder retraining, pelvic floor strengthening, diet. Those are all really great things. And then the medicines we talked about, the newest class of medicine tends to have less side effects, but is very expensive. The older classes of medicines, which can be effective, have a really high rate of dry mouth, blurred vision, constipation. And, this says 72% of people stop their medication within 6 months. I find that number to be much higher. And the only people who stay on the medication I find are people who it really helps their symptoms and it doesn't cause any of these side effects. So if people fail those medicines and they fail conservative therapy, then it's time to consider advanced therapies. Advanced therapies are things like InterStim neuromodulation. There is medications you can inject like Botox. For Botox, a doctor would put a scope in your bladder and use a tiny needle and inject Botox in a pattern around your bladder. And what that does is it basically paralyzes the bladder, and it can be effective, but it's not usually something patients are able to continue to have over and over because it wears off, just like when you put it in your face or any other part of your body. It wears off after an amount of time, whether that's 3 months, 6 months, a year for some people, but it is something you have to repeatedly do. As an alternative to that, doing PTNM or PNE, there's a lot of different acronyms, but PNE, peripheral nerve evaluation, is what we do in the office to tell who might be a candidate for permanent placement of a neuromodulating device. So I tell people all the time, I'm not promising you that this is going to work, but I will tell you that when it works and it works well, it can be life-changing for a lot of people. This is the tibial nerve stimulator. And this is different than peripheral nerve evaluation. This, you come in and it takes about 30 minutes. You sit in a chair, they put this tiny little probe in your leg just like this, and then they stimulate your tibial nerve. The idea behind that is controls your bladder nerves through a peripheral nerve. It can be effective. I find it not to be as effective as the PNE and the neural stimulator that is implanted, but it can help some people. It has about a 75% success rate. And the ones that it usually helps pretty well. And it can be repeated over time if you can do kind of follow-ups and maintenance of that. And it can be really helpful. This is the P&E I was telling you about. It's been around since 97, so we have a lot of experience with it. That's a really long time. They have made it a lot easier for patients, and the patient experience is a lot better than it was when I started doing it in the late 90s. And the equipment, as you might imagine, is more streamlined, more sleek, and patients have a very easy time with it. And now you have a handheld device that you can look at yourself when you go home and modulate it. It's very, very easy. The way we do the P&Es or the peripheral nerve evaluation is you come in and you lie on your belly and we numb up a little spot above your buttock, and I run a little filament down to your pelvic nerve. And that little filament, there's a battery attached to it. You wear a belt home, just like this gentleman's got on in this illustration, and you wear that for about 3 or 4 days. It takes anywhere from 10 to 40 minutes to get that little filament in. It's uncomfortable, but it's not painful to put it in. I've never seen an infection. I've never had anybody have a big problem or any kind of side effect from doing the testing. And for instance, I saw 2 people back today that I sent out with the test, and they both came back today, and we took the leads out and I asked them how they did. And I have a printout that their machine sends me that objectively tells me how their bladder did with the test. But one was an older gentleman, one was a younger lady, and they both said, wow, it was incredible. It really changed how I urinate, and I'm so happy, and I want to go forward with the next step, which would be to put the device in, and I'll explain how that goes in a minute. I left this slide up so you guys could peruse it. It has a high satisfaction rate with the people who stuck with it. It does, I believe, it provides better relief than any of the medicines on the market, and I think it is one of the best things you can do. When it works, it works. The people that need to talk to their doctor about this are people who have significant symptoms or have had symptoms and gone to urologists in the past and didn't feel like the medicines worked, didn't feel like anything else worked, and they kind of feel like they're at the end of their rope. How we put the implant in. You come to the hospital, you're lightly sedated like you're having a colonoscopy, and we make a tiny little incision about this long, about 3 or 4 centimeters, right on the top of the buttock. And I run a permanent filament down into your sacral nerves, and then I run a lead down that's designed to stay permanently. And then I put this little pacemaker thing, it's about that big and about that wide, and we put it underneath your sub-Q fat and sew that up and bandage it, and you go home. That whole process takes 30 to 60 minutes. Go home same day, and you can start using the device immediately. It takes a couple weeks to kind of fully heal. I've never had anyone have significant pain from that. I've never seen an infection. I've never seen anybody have any infectious problems or bleeding problems or any of that kind of stuff. We put it in a place where you don't feel it when you're sitting. And worst case scenario, you have it put in and it just doesn't work as well as you'd like, and we have to take it out. Now, in the 90s, when we started doing these, we didn't have the ability to do the in-office test. And so there was a high rate of taking them back out because you just didn't know if they were going to work. Now with the in-clinic testing, and we have the objective part and the subjective part, it's very uncommon to put one in and have to take one out. So that saves people, time and money and hardship, because it's no fun having procedures done if you don't want, no one wants to have a procedure if they don't have to. That's kind of the long and short of how this works. Is people ask, well, if I'm going to have this put in, will it set off a metal detector? No, it won't. It will be visible on imaging. There is not an indication to have this be MRI safe technically until recently. Now they have MRI safe tines and leads. You can have an MRI now if you have this. If you have this and you need an MRI, we can find a way to get you an MRI. If you have an old one in and you need an MRI, there have been several clinical trials run that show it's completely safe. If it was really needed, it was something we could do. Okay, go ahead. Now's a good time to take questions.
Okay. First question.
No age restrictions at all. It works in people of all ages. I've put it in very young people and, early 20s. I think the oldest person I put one in was, 85, a gentleman that was having severe nocturia. He was getting up 15, 20 times a night. And we went through the pathway of everything. And then he was able to finally get relief with the InterStim. So the first part where we did the trial in the clinic, you wear that little belt and you sleep with that on. And I haven't had anybody complain that was a problem for them. Once the device is implanted, it's all completely internal in your body. And, if a urologist came and saw you in the shower, they'd never know you had it either. No one can see it. No one can tell you have it. And it just stays inside like any implant. Like if you have a knee replacement, that implant is in your body and stays in there. It's underneath your skin.
Dr. Woodruff is available for in-person and telehealth appointments at our 92nd Street office in Scottsdale. For more information or to make an appointment, please visit us at ArizonaUrologySpecialist.com, where self-appointment scheduling is now available. Thank you so much and have a great evening.
All right, thanks, everybody.